supported my recovery in relation to the responses of my treating team and staff. So validation, especially because those with BPD usually come from an invalidating environment. Now, this doesn't mean excusing and allowing me to remain in the victim mentality, but it does mean acknowledging that what happened to me was not my responsibility, but unfortunately, recovery is my responsibility. No one else can do it for me. Vanessa is really good at that. Your validation, in turn, helps me to learn how to validate myself and believe in my capacity to make changes. Trust in a strong therapeutic alliance. It's extremely difficult to accept that what I see and how I perceive things may actually be distorted. That my experiences, just because they're familiar or normal to me, aren't necessarily healthy, right, or acceptable. Knowing my treating team were trustworthy allowed me at times to follow their advice, even if everything within me screamed against it. Trust is the foundation to any positive progress. So what supported the development of this trust? Time, patience, understanding, and genuine authentic care. In moments where I felt cared for, understood, heard, and when my team listened and took the time to get to know me, I was increasingly enabled to share my vulnerabilities. This in turn allowed them to identify more accurately what I needed, what kind of treatment would be most effective, and ultimately led me to being open to accepting their help. Remembering that it is not what you are treating, but who. By getting into the habit of labelling the illness rather than the person, you enable me to do likewise, recognising the internal conflict between what the ED, for example, wants and what the healthy self wants, which empowers us or me to then respond differently. Closely linked to that is remembering that you're working with, not on or for people. It's far more empowering when, as patients, we can be co-collaborators in our diagnoses, treatment and recovery. Fourthly, putting the responsibility back onto me for recovery. Trying to take the eating disorder, for example, away from me and trying to convince me why it's bad and why I don't need it never worked. If anything, it only strengthened my eating. You cannot force recovery. Obviously, there are times where force feeding, for example, may be essential for the preservation of life, and I've encountered this more times than I care to remember. However, when not in such a critical condition, having my team force me to take responsibility for my own recovery was far more effective in the long term. Danae would say to me, "I'm not going to force you to eat. I'm not at home with you. You don't have to recover if you don't want to. It's up to you. But you know the consequences if you don't." Even now, Danae always says to me, "You don't have to change anything if you don't want to. It's up to you." But how's that working for you? Is it effective? She's not going to get into a power struggle with me, and she's not going to force me to do anything. It's my life and I can choose how I want to live it, but is it effective? Do I really want to continue in the way that I'm going? I used to hate it, as essentially I wanted her to do the hard work for me. And in a way, my frequent hospital admissions were an attempt to force someone else to be responsible for my life. You were responsible for keeping me alive, for feeding me, for keeping me hydrated. But while someone else was responsible for my life and recovery, it only resulted in temporal or superficial change. I had to come to a place where I chose recovery. Change is painful. It's uncomfortable, it's scary, it's unpleasant. But how I choose to accept and embrace it or not determines my level of suffering. I also found that a collaborative, multidisciplinary team approach was most beneficial. My case manager, psychologist, psychiatrist, GP, dietitian, counsellor, support workers and so forth were all in frequent communication with each other. I also accessed group therapy and peer mentoring. Viewing change and recovery as a process, not an event. This freed us all to view lapses and relapses. Viewing recovery as a process. So it freed us to view lapses and relapses not as major failures, but approach them with the perspective of what could be learnt, what insight could be gained, and how I could get back on track sooner this time. Re-engaging in life. Building friendships and a life outside of the hospital and my mental illness. For me, that's been re-engaging in netball, my church and my deaf community, and in pursuing artistic endeavours. One of the things that helped me stay the course of recovery has been contributing to others and engagement in advocacy projects. I always felt like the consumer, a dysfunctional, broken, unwell patient or client, but now I'm also a contributor, and that's incredibly empowering. I developed the Recovery Resources package and wrote the meal support booklet, which can be accessed or ordered online at recoveryresources.com.au, which was significant in my recovery, as it was important for me to maintain authenticity and credibility as I developed them, and this has often propelled me forward even when I felt like giving in. My recovery has, and continues to, require pharmacological, physiological, and psychological treatment. Pharmacologically, at this point I need to continue taking my sertraline and quetiapine, as it helps keep the PTSD symptoms and anxiety at a manageable level as I continue to work with the underlying issues. Physiologically, the years of starvation and abuse to my body have left a footprint on my health. And while the body is rather resilient, and I am healing, I continue to see my dietitian and GP on a monthly basis to monitor my bloods and ensure I get adequate nutrition. And psychologically, I check in with Danae regularly to brush up on my DBT skills, maintain accountability, and get some support in applying my skills to new areas of my life. And I also engage in trauma-informed therapy and see Dr. Warren, my private psychiatrist. Before I finish up, I just want to say thank you to the many of you who demonstrated care, compassion and passion in your care of me and for your support throughout my journey. I know I haven't always made your job easy, and there are many times where I've caused amazingly caring staff to cry and consider quitting, where my behaviours have caused distress, or you've experienced vicarious trauma through listening to me share of my own experiences. But what you do and who you are is incredibly valuable, and I'm alive today and participating in a life worth living because of you guys. There are times you may feel like you're talking to a brick wall, that what you say goes in one ear and out the other, that what you do and the support you offer has no lasting impact, that you're wasting your time. But that's not true. Once I was ready, the conversations you had with me, the seeds that had been planted, even though it appeared they were sown into barren and dry ground, are now bursting forth with life and fruit. Even when you can't see any tangible progress, what you say and do really does make a difference. So thank you. And just here are a few photos of my brothers, because they're gorgeous. And here's another plug for my website. Thank you.
Thank you so much for that amazing talk. I'm actually tearing up a little bit. It was incredible, and it's definitely why I do my job and why a lot of us also do their jobs, to see experiences like yours. And thank you so much for sharing that with everybody. Does anyone have any questions for Sarah about her DBT journey, BPD diagnosis, or anything else that she's talked about in her talk today? Or comments? Doesn't need to be a question.
It's a comment really. I've been in the system, my name's Helen, I've been around for a very long time, and 40 years ago I used to work up the top and deal with a lot of people who were traumatised like you, and it's really lovely to see such progress over the last 40 years, but unfortunately it's a silo up there. So the people who never got out, who are still, like you said in your little things, psychiatrists and nurses who are trapped and can't go home, it would be, I think, wonderful if you could present to the staff that are sort of trapped in that system, because they never get to hear these wonderful stories or see these wonderful outcomes. And I was just talking to a lady as I came in the door. There was an artist in residence here 30 years ago who did a lot of work with people with BPD, but we called it lots of other things back then. And there's a mural around the side that was created by those people. And they tried to stop the mural because people had to break up tiles and stick them on the wall. And when they were breaking up the tiles, obviously every now and again someone would have a little sore at their arm or whatever. And Neil would just say, oh, that's all right. Similar, like just validate what they were doing and then say, come back and feel well. They wanted that mural to be shut down and not completed, but if you have a look when you leave today, it got completed by all those participants. So that was a wonderful testament to him. But thank you very much. And I'd love to facilitate you speaking to some inpatient nurses, and I think it would be really valuable for them. Yeah. Thanks.
Any other questions or comments at the back?
Hi, Sarah. Firstly, thank you very much for sharing. My name's Nerida. I've been a special needs teacher for 30 years, but I'm relatively new to mental health recovery. Thank you, and I'm aware that I just wanted to ask you two questions quickly. You mentioned that you weren't able to move to the second phase of your. I don't want to put you on the spot, but I'd be really interested at some time to hear, was that purely a financial, is that, because I'm aware that it's very expensive.
I don't think it's actually offered
I can answer that question.
Okay.
We unfortunately don't offer phase 2 of DBT treatment in public mental health. So phase 2 is treatment of PTSD. There has been recent a development of a recent program called DBT-PE, which is phase 2 DBT, and there's only a handful of us that have been trained in that. And we've sent a proposal to the executives to try and embed that into the service, but it hasn't gone ahead, unfortunately, yet.
Could be a point for lobbying for some of us.
Yes,
lobbies. Being naughty. And the second is, I was fortunate enough to work with a community-based organisation called A Place to Belong at West End, which a lot of you may be aware. And they are very linked in with the UQ, but other universities too. And I was just wondering if you'd ever done or considered doing offering of services which is actually paid as a guest speaker, especially for the Masters for OT students. And I could give you the link to those people if you want. Also, Masters of Counselling, which is something often they bring in guest speakers. And I think it would be just incredibly invaluable because as an educator, and you did that, start where we need to educate our students, our mental health support students, and our doctors in particular. Medical profession get such little time to hear from the lived experience of which you have a lot of knowledge. And uniquely, thank you. Sorry, thank you very much.
Thank you. I think we've got time for just one more question or comment. Nobody? Oh, yeah.
Just a little comment. I really appreciated your insight. I think as a nurse, you see one side, which is what practices are good, but having your views actually probably brighten up that big picture. And I think you should share that, especially at an earlier phase with education. I think it's important because the stigma, we learn things along the way, and sometimes we learn not so good things along the way. And I think what you've done is open an insight which needs to be shared, especially to us professionals. We do our best, but to get a good insight like this, I think it touches a lot of us. Yeah, it's great.
A sneaky another one.
Thanks. So I'm Trish Carter, Engineering Consultant here, and we organise guest speakers to come and talk to students and things. And the goal identified probably a couple of years ago that a big gap was the new grads coming through and having lived experience team come and talk to them. And we just did the BPD workshop more recently and had a guest speaker come to share his lived experience. But yes, Sarah, I'm happy to have a chat to you as well and get you linked if you wanted to. And yes, ours are all paid as well. So I think it's slowly moving forward. And I take your point, Helen, has taken a long, long time, but they've slowly moving forward with that.
Queensland. Yeah, and made them sit in the front row. So, thank you very much. Okay, so now for something possibly not as emotive, so we can all recover. I'd like to introduce Melissa Kent. She's a registered psychologist with a clinical endorsement and has a special interest in treating people with BPD. Melissa has advanced training in DBT and trauma processing. She is the founder and director of the Glow Centre, which is a private psychology clinic in Kenmore, and is currently halfway through completing her PhD at the University of Queensland. Melissa is passionate about breaking down the stigma of BPD and advocating for consumers, and today she will talk to you about a multi-site research study of DBT across Metro North and Metro South. Please extend a warm welcome to Melissa.
Thank you very much, Sarah, for your presentation too. I think it's a wonderful introduction to what I'm going to talk about, which is less emotive, as you said. However, it's talking a little bit about the nuts and bolts of a big part of your journey, which was DBT. So, a really quick, basic intro. Can you hear me all right? Yes, excellent. To the research that we're doing across Metro North and Metro South. The research project itself is being headed by Sarah, the Chief Investigator, and it's moving along really nicely. So to give you some background as to why we're investigating this particular issue is we're talking about, in general, borderline personality disorder treatment for BPD. We understand now that it's a common and serious psychiatric disorder, and it's associated with high levels of health service utilisation and psychosocial impairment. So what we know at the moment is that DBT is the most researched and the most widely implemented intervention for people with BPD. It has a lot of really great outcomes. Specifically, it leads to reductions in BPD symptoms themselves, suicidality, self-harm, health service use, and general psychopathology. But what we also know is that to deliver DBT, it's incredibly resource intensive, and the people who deliver it must be highly trained. So therefore, the actual dissemination of this treatment, especially into public mental health, is not very wide. So what the research more in the last decade has started to look at is whether DBT works in routine clinical settings. Because originally when it was developed in a university research clinic where everybody who delivered DBT was highly trained by the people who developed it. People went there specifically for that. There's lots and lots of resources, lots and lots of time. So we know really well that it works in that kind of setting. And more recently, people in the field have started looking at whether DBT actually works in routine clinical settings, the ones that we work in, and specifically frontline mental health clinicians, case managers, and in the public mental health systems, the programs that we have there. And it appears, good news is, it appears that it is. It is also effective in routine mental health settings. Another direction that the research has moved into is why DBT works. And that's consistent with a lot of the research into psychological therapies in general, is we might understand that they do work on some level, but understanding why, and that's what we call the mechanisms of action. Why, what actually are the things that drive the change that we see. In DBT, there hasn't been much research into that, it's just emerging, but what it looks like so far is that the skills that are taught are the biggest mechanism of action for DBT. The skills that are taught and the practicing of those skills between sessions is the real mechanism of action. So, but what we don't understand, and that's where this research comes into it, is the relative importance of each of the DBT skills modules, because as many of you would know, it's a long program over time, and it involves 3 modules of skills training, twice for a standard dose. So it would be really helpful, we think, to understand the relative importance of each of those modules so that we could possibly do treatment that's much more targeted and therefore quicker. So that's what we're looking at in this particular research. You can next do it. So to give you an idea of the specific project that we are doing, at the moment it started off with getting some ethics approval. And signed contracts and site-specific agreements between Metro North, Metro South, universities, my university, Sarah's university, lots and lots of people involved. And eventually we were able to start collecting data in November last year. We have a team. Sarah's the chief investigator, and you'll see that there's a representative there from each of the hospital sites that have DBT programs in Metro North and Metro South. So for those of you who don't know, the Royal Brisbane and Women's has a program, the PA, Caboolture, Logan and Prince Charles all have DBT programs. So to jump back a step, back to BPD specifically, because it's difficult to understand DBT and try and understand why it works without understanding what it's targeting in terms of the specific difficulties related to difficulties that people have who have the diagnosis of BPD. So we've got 9 criteria here. They're the DSM-5 criteria. You have to meet 5 out of 9. A lot of people are probably familiar with that, but what it actually means down in the small print, what that actually means is that any of these symptoms, and a cluster of them is associated with really high levels of health service utilisation. So if we took, in Australia, they took a sample of people who were outpatients of mental health services, 23% of people had a BPD diagnosis, and in inpatient populations, 43%. So one little diagnosis, a significant proportion of the population of patients. The clinical hallmarks of the diagnosis are emotional dysregulation, impulsive aggression, repeated self-injury and chronic suicidal tendencies. So traditionally, as what you're talking about, and a lot of us who've been around for a little while, we might be able to remember that traditionally it was considered to have a really poor prognosis and that there were no effective treatments. We know that that's not true anymore. However, it can still persist in different places and across different times. But happily, the tide of research and clinical opinion has turned. And that's where DBT comes in. Oh, you did it. So, this is the nitty-gritty of the research as it is at the moment. There was a Cochrane review, which is the highest level of analysis, I suppose, statistical analysis or evidence that someone can put together for something. And what it concluded was that when we talk about treatments for borderline personality disorder, only DBT has enough evidence to recommend it as a robust treatment. So there are other treatments, but DBT is the only one that has enough evidence at the moment to recommend it as a good treatment. And this was supported again in 2018 with another systematic review. So the bottom line is that there are a few specialised treatments. DBT is not the only one, but it is the only one that has enough evidence to recommend it robustly. But it's also quite difficult to implement because of its nature, length, intensity. Can you talk a little bit about DBT? Are many people familiar with DBT? So some people probably already know all of this stuff. For those who don't and would like to hear it again, we're going to go through just a really broad overview of DBT. It was originally developed by a lady called Marsha Linehan in Seattle in Washington. at the University of Washington. In 1991, it was the first randomised controlled trial. So the first trying to apply treatment to people who were traditionally, people were nervous to treat or try and treat. So people who were highly suicidal. She was the very first person who did a randomised controlled trial. It was described as groundbreaking at the time. And she's gone on and over time to publish a really good series of really well done studies and a really clear manual that's really easy to follow, really well replicated studies. And essentially it's a cognitive behavioural framework, but it combines change-focused strategies that we might see in our usual kinds of therapies with more acceptance-based philosophies that you might more likely see in more Eastern leaning things. And she was the first one to put those two things together in some kind of therapy. There are 4 modes of DBT, and each of them has its own function. So, skills training groups. This is a fully adherent, comprehensive DBT program. Okay. So we have skills training groups, usually once a week for 2 to 2.5 hours, done in a group. That's where you learn the skills. It helps participants acquire skills in a lot of different areas, 4 specifically: mindfulness, distress tolerance, emotion regulation, interpersonal effectiveness. So that ties in nicely to some stuff that you mentioned, Sarah, in terms of distress tolerance and emotion regulation. That's what we're talking about, those skills. There's also individual therapy, which is also weekly for an hour. The purpose of that, the function of that, is to enhance motivation to change and to practice the newly acquired skills that people are learning in the skills group. There's also between session coaching is another mode, or phone coaching, which helps people to transfer those new skills into their everyday lives in the moments that they actually need to apply them and when it's actually going to make the most difference. And then the 4th mode is a consultation team. So everybody who's on a DBT treating team meets usually weekly for about an hour and a half. And the purpose of that is to support therapist motivation and skills and make sure everybody is still staying really nicely within the DBT framework. So that's why it's so intensive, lots of modes. And this is what a standard curriculum looks like. So this is how much time, over time, a standard comprehensive DBT program would take. You can see that it's broken, might use a laser pointer. You can see that it's broken into 3 modules. Distress tolerance is one of the modules, and it goes for 8 weeks. Emotion regulation is another module. Interpersonal effectiveness is another module. This one here goes for 9. This one here goes for 7. At the start of each module, there's 2 weeks of mindfulness skills taught. So they're taught 3 times, 6 times, because a standard dose is for all of those modules twice over 12 months. Okay, so you do this one, and then you do this one again. The order doesn't matter. There's no empirical evidence to suggest any particular order is better than the other. And so, yeah, the mindfulness skills are embedded into each of the modules. So we get 12 weeks of mindfulness over a 12-month program. Does that make sense? Any questions about that? Pretty standard. So I'm going to talk a little bit about the research again. I'm just going to go quite quickly through this. Basically, all of the research at the moment tells us that DBT is really, really good, and it's probably good for a lot of people, probably good for everybody to have those sorts of skills. But it's very good specifically at achieving really specific outcomes. Especially the reduction of suicidal and self-injurious behaviours. So over time, people have researched DBT, but there's been a few limitations in a lot of the research. Most of the research so far that looks at evaluating DBT usually collects only one particular type of information. So it might be objective or subjective. So it might be looking at how often somebody goes to hospital, or it might be subjective measures, which is somebody filling out stuff, saying how they go before and after they've done it. Often some of the research is done on just one site rather than multiple. No control groups, and whether people are actually doing DBT as it's meant to be delivered isn't often evaluated in these studies. So we don't actually know if we're really evaluating it truly as it's intended. So our research aims to address all of those limitations as well. So bottom line, it's really effective, and it's effective in routine settings, but we still don't know how or why it works. There we go. So we looked at, people have started looking at the mechanisms of action. So yeah, the upshot of that basically is that the skills are most likely the mechanism of action. More frequent skills use or practice is associated with better outcomes. But in terms of which skills are associated with which outcomes, we don't know yet. So actually I might skip over that one and go to the next one. So what we're looking at in our particular research is the relative and collective impacts of the skills on the acquisition of these skills. So essentially, does teaching distress tolerance skills improve people's distress tolerance? Does teaching emotion regulation skills improve people's emotion regulation? Does teaching interpersonal effectiveness skills improve people's interpersonal effectiveness? Or is it something else altogether? Is it that teaching distress tolerance skills improves people's emotion regulation skills, or vice versa? Or is it a combination of all of them, which I suspect it probably is? So that's the main question we're trying to answer. We're also trying to look at each of the specific skills modules and their effects on BPD symptoms, suicidal behaviour, self-harm. So if any of those particular skills are more or less effective with those outcomes. So you can kind of see how that would help to target the kind of skills that we might teach. So our hypotheses are that distress tolerance skills will lead to increased distress tolerance, etc., across all of the models. We don't know that, but that's what we're predicting. So the methodology, what does it look like? How are we evaluating this? We've got a nice little flow chart here. What this shows is that when someone's referred into one of the DBT programs that's in Metro North or Metro South, there's some diagnostic assessment, suitability for the program, and at that point we invite people to participate in the study. So whether they want to participate in the study or not doesn't affect whether they get to do DBT or not. It's nothing related to that. We have a control group. So for some people at one of the sites, while they're waiting to get into DBT, they form a control group. Spots becomes available. People do the program, and then they fill out assessments at the end of each module. So at the end of each module, we're getting an idea of how well that module has improved particular skills. There's 7 treatment groups and 1 control group, and 112 is the total sample size expected, which is pretty good compared to a lot of the other studies in the field. So the participants are any adults who are open to any of the services, and they have been accepted into the DBT programs. They're recruited, they're asked at the point of being assessed, and maybe a little bit after, during pre-commitment, if they want to be part of it, and then they participate then for the first 6 months. And consent can be withdrawn at any time. And this is just some ideas to give you an idea of the measures that we're using. So we're using measures of emotion regulation, measures of distress tolerance, and measures of interpersonal effectiveness. So we're wanting to see if any of those change. We take those at the start of the module and at the end. And any change we can then say is because of that particular module that they've just done. We also take measures of BPD symptoms, how often people are self-harming, their service utilisation from SIMA, so how many times perhaps they've gone to emergency or been admitted, how long they stayed in hospital, and alcohol use. And we're also measuring a few different other things that we know or we think are probably associated with outcomes too. People's mindfulness, PTSD, dissociation, the alliance between the participant and their therapist, and how often people are actually completing their homework or using the skills. We're measuring the adherence of each of the programs to DBT as a whole, as well as adherence to the actual way that it's meant to be delivered in each of the sessions, the skills group sessions. So we can say for sure that what we're measuring is DBT the way that it was meant to be delivered. So, in conclusion, we know that we accept now that BPD is a common and serious psychiatric disorder. It's not a flaw or a behavioural problem. DBT is the most widely researched treatment for BPD. We know that it's effective, but we don't know why. So what we are trying to do is figure that out by looking at it being delivered in routine mental health settings right here in our little corner of the world. And hopefully we'll be able to make some conclusions then about how we can deliver particular skills to particular people in terms of what they need at that time and what's going to give us the biggest impact in terms of the skills that we teach. So that's the research project in a nutshell. That's good. All right. So does anyone have any questions? Yes.
Yeah, thank you. So I just wanted to find out, like, the different groups of people, children, adolescents, adults, and geriatrics. So with the DBT skills, do you just provide the same skills for everyone? Because I was thinking with the geriatrics, there might be issues with cognition declining. So do they still get the same skills regardless?
Did everyone hear that question?
Well, in terms of, well, we can talk about adolescents. There's a specific protocol for DBT for adolescents. There's also, I don't know if there's a specific protocol at the moment, but for children, there's a lot of people who are trying to adapt the skills and that sort of stuff to teaching them to children. With regards to older people, I don't know that there's any specific protocols around that. So, yeah, to answer that question, I suppose, yeah, it would depend on each person's level of functioning, I suppose. Yeah.
And we have found that in our adult programs, the individual participants are required to have a certain level of IQ functioning and ability to retain information and to concentrate. and also literacy, because it's quite information dense, the program. So if clients are possibly going to struggle through that, then we won't put them into the 12-month DBT program, and we'll try and target it in a different way.
Thanks, Kirsty. Just a congrats program on the e-speak. I was just wondering, is there a plan to utilise, so if DBT still work, is there any plan to implement something else?
Well, that would be fantastic. Well, we're struggling to create shorter programs in community, so to get it on the inpatient unit would be really challenging, but it's a really good idea.
Because one of my concerns is just that we see patients come in who are doing a DBT program and then they come into hospital and all the skills they've got, like none of the nurses on the inpatient ward trained.
It's a funding and resources issue, so lobbying is good. You're welcome to communicate to the people who have the money and the local members of Parliament.
Any other questions? Is that research or?
Hi, I'm Chrissy. I've actually lived experience in worker and things like that. I've actually been very fortunate to experience DBT through the private health system, and I did it for 2 years and do it now doing utilisation and things like that. And it's just been a really fantastic process, and it's really made a big difference in my life, and a lot of people that I know that also attend the program and things like that. And I guess that's why I'm sort of so passionate in the peer work side of it. But I also know that when I am an inpatient and things like that, they've got the very basic DBT, like if you do like the groups sessions as an inpatient, it just touches very basic skills and just dot point. So, you know, people can chat about it and just share some basic skills, and it's, yeah, I've found that that's made a lot of people very interested in attending DBT. They're like, how do you get into it? And like I know it's very, very different public and private systems and stuff like that, but yeah, it really, yeah, it's very sought after now and things like that. But yeah, it's an awesome program.
Thank you for your kind comments.
And that's why we want to make it as widely available as possible. Yeah.
At the moment, approximately 18% of the population diagnosed with BPD across Metro North receive DBT. So that's over 80% who are receiving non-evidence-based treatment.
Is that just within the public sector?
Yeah, that's statistics from our service.
Oh, so they don't, like public and private don't share?
I have no
Sorry.
idea. I don't have access
Oh
to
no,
this.
it'd just be interesting to see how much more accessing through private systems as well. So as a collective, I guess, would be interesting to see how much the numbers would increase.
When are you expecting to have kind of results of this study?
May 2022, we will have enough.
We have data, as you know, but it's not enough to provide any kind of reliable outcome. So the power is not sufficient if you understand power. It just means the number of people needs to be lots and lots in order for the results to be reliable.
But along the way, we're hoping to put out in sort of, you know, like progressive results and that sort of, you know, hopefully in terms of,
Is there a way to sign up for that? Like to get notified?
When the results come out,
Yeah.
I'll let you know.
All right. Thanks.
I think that's on the participant information and consent form that we
have you thought about opening that up to, like, the pool up to community settings that might be offering BPT skills groups? Because, so I work for NEMI, and we've now got PHN funding in Brisbane for one of the 3 hubs. And part of that is that psychotherapies funding, and we haven't implemented it yet, but looking at how we might implement BPT groups and whether that is something that we could feed results into the
Well,
study.
we're looking at fully adherent DBT programs, so that sounds like that would just be a skills group only program, which would be really great to evaluate, but it wouldn't fit into our inclusion criteria. Yeah, but it's definitely worthwhile evaluating. So just a really quick note about future research and program implementation, because we're always thinking about how we can improve our services, and research reforms are really